Hello, welcome back. Alright, I'm gonna read some more of this book. So we were on chapter 2. And it's been a couple days since I recorded the last chapter reading or whatever. So I don't know. My period started, and then immediately the hormones were like sort of chill. The PMDD inside me, that little demon, it was soothed. I was given a blankie, and it is calmer now. I don't know. One sec. I'm gonna take off the cover on this book so it doesn't make as much noise. Hang on. Voila. Perfect. Okay. Alright. Let's see. I'm just gonna get right into reading, honestly. Chapter 2. Skin is more than skin... Oh, shit. Sex is more than skin deep. Clearly, I can't read. Yeah, honestly, sometimes whenever I'm doing... One thing I'll say before I start this is whenever I'm doing these, it feels like when you have to read in front of the whole class. And I'm just like... but at the same time, it's fine, whatever, the whole point of all of this is partly because I want to keep it, in perfect and chill and, calm, chill, but, anyways, okay, I'm just gonna start now, but yeah, I just, keep in mind I'm probably a decent bit dyslexic, not even probably, and it's complicated. It's one of those, if I had been born later and as a white boy, did I already say this before? I feel like I've said this before, or maybe I've just said it to, other people. I think I'm a little hyper. I'm gonna genuinely just read, because otherwise, it's gonna be 20 minutes in, and I'm not gonna have realized that I've been talking for 20 minutes, and it will have been about 50 different unrelated topics. So, anyways. Okay. Not long after I applied for and was granted a research position at Brown University, I submitted a proposal for a didactic presentation at the annual meeting of the Society of Academic Emergency Medicine, also known as SAEM. The presentation was titled Women's Health and Gender-Specific Research in Emergency Medicine, Yesterday's Neglect, Tomorrow's Opportunities. I was beyond excited about what I was discovering about women's bodies and their physiological and biochemical uniqueness, and I couldn't wait to share this with my peers. Surely they would be as stunned and galvanized as I was. Honestly, I was shocked that my proposal was accepted. I was a newbie, a mere junior physician barely out of my residency. Feeling empowered, I rounded up 3 experts to discuss sex and gender in relation to emergency medicine. We all prepared our slides and notes and practiced our different roles in the presentation. We flew out to Chicago for the meeting. I don't think I've ever been so nervous. This was my chance. I was going to start a conversation that would change emergency medicine forever. Finally, it was time for our presentation. The previous didactic wrapped up and the room was efficiently changed over. My colleagues and I came in with our notes and slides and set up quietly. The room was empty. But that was okay. People were coming from all over the hotel. It would take time for them to arrive. I fidgeted in my seat, watching the clock. 5 minutes to go. 3 and 2, and then it was time. I looked out over a sea of empty chairs. The room was set up to hold 60 people, but only 2 seats were taken, one of them by my colleague and friend, Dr. Libby Nestor, and the other by my male office mate from Brown, who'd stopped in to cheer me on before heading out to the airport. I had no idea what to do. My fellow presenters and I just sat there staring at each other. Eventually, as if by unspoken consensus, we all stood and started packing our things. Our big idea, it seemed, was dead in the water. This was such a powerful moment for me. Here was a conversation that could change the face of medicine as we knew it. Something that could mean life or death for millions of women around the world, millions of women around the world, and no one showed up. I understand now that my fellow physicians didn't skip my talk because they didn't care about women's health issues. They simply didn't know what they didn't know. In some respects, I was ahead of my time. Go you, Dr. What's her name again? Dr. McGregor. Yeah. Okay. Research, education, and the work of actually providing care to patients are often treated as separate entities in our everyday medical reality. However, the knowledge that researchers gain in... Oh my god, that was a burp. One second. Okay, we're good. Sorry. Research, education, and the work of actually providing care to patients are often treated as separate entities in our everyday medical reality. However, the knowledge that researchers gain is incorporated into medical education, which eventually has an effect on bedside care. If I wanted to create real, lasting change within modern medicine on behalf of women and their unique bodies, I would have to address all three of these areas simultaneously. I would have to educate researchers, inspire medical students, and serve my patients in a new, more enlightened way. My Sex and Gender Women's Health Collaborative has given me momentum to do exactly that through fellowships, lectures, programs, meetings, and research. In this chapter, I'll reveal the many ways in which the current medical establishment isn't set up to support women's bodies, and how our flawed belief that women's bodies are equivalent to men's has negatively impacted women's outcomes at every level of care. We'll explore how in every setting, from pharmaceutical laboratories to hospitals to physicians' offices, the male-centric model of medicine is ubiquitous, meaning it is everywhere, and nearly unquestioned, and how understanding the impacts of this male norm can mean the difference between life and death for women across America, and, dare I say, the world. Alright, the evolution of male-centric medicine. Prior to the 1970s, medical research and medical practice in general was nowhere near as closely regulated as it is now. Today, every federally supported study and drug trial must be approved and monitored by an institutional review board to ensure that the study is ethical, presents minimal risks to participants, and is structured in accordance with solid scientific practices. 50 years ago, however, the world of medical research looked very different. It was essentially the Wild West of medicine. Every new drug was likely seen as to be safe and beneficial, and pharmaceuticals were tested and distributed with very little regulation. Clinical trials did not acquire approval by a review board, nor were they subject to oversight by any neutral party. This carefree approach changed drastically as oh my god, I'm so sorry, guys. I need to get a little more light. Hold up. Okay. This carefree approach changed drastically after numerous unforeseen consequences from new drugs and research impacted the health of tens of thousands of people. One example of this was the drug thalidomide. I said that wrong. Thalidomide. Okay. How anticlimactic. But actually very climactic, because this is a big, important thing in history. Okay. An anticonvulsive, also marketed as a sleep aid and a nausea reliever for pregnant women, thalidomide was available over the counter in Germany and by prescription elsewhere. At first deemed safe and effective for all users, it was eventually determined to cause severe congenital malformations in fetuses, but not before vast numbers of pregnant women had been innocently consuming it. Over 10,000 babies were born with missing or malformed limbs, damaged hearts, eyes, or digestive organs, or other major physical handicaps. Many survived only hours or days after birth. This tragedy, which affected families across Europe, Canada, and America, prompted an international investigation into drug research and human testing practices. The eventual outcome of this and many other concurrent investigations was the creation of the first quote-unquote informed consent laws for pharmaceutical trials in humans. It wasn't until 1974 that protection for research subjects was written into law. The National Research Act created National Commission for Protection of Human Subjects of Biomedical and Behavioral Research, tasked with developing guidelines for medical research involving human subjects and regulating the use of human experimentation in medicine. Under this set of guidelines, pregnant women and women of childbearing age were considered protected subjects, and unsurprisingly, given what had happened with the thalidomide, many researchers opted to exclude them from their experiments altogether, rather than jump through the hoops necessary to include them in a safe manner. At the same time as medical research evolved and became more regulated, researchers noticed that monthly female hormonal fluctuations created hard-to-account-for variables in their trials. Because, I'll add here, in case anyone doesn't know who's listening, female people and some intersex people, basically, will have, because of usually the influence of the ovaries, mainly the ovaries, but also, the uterus is involved and stuff. There's a monthly creation and recharging and all of this of tissues to basically create a pregnancy that is then discharged, and that's what we call our period, right? But it's caused by and also influences the levels of specific hormones that are predominantly female hormones. And those female hormones, quote-unquote female hormones again, but, those impact everything in the body differently. Earlier we had talked about the estrogen protective effect in another chapter, as if I've read, 10 chapters of this book already, but, there's, that effect. There's, for example, for me personally, I'll definitely be making videos on this in the future when I figure out how I want to talk about this, but, people don't talk about hormones, and I've more recently kind of been understanding the impact of, my own hormones on my own health, but, there's a sea change and difference between when I was, a younger person, post-puberty, having, the influence of having a period and hormonal changes and stuff that run on this, monthly resetting cycle. I wasn't necessarily realizing that would impact everything from, pain tolerance to energy and, sleep and acne or appetite, so many different things. And most males will run on this more 24-hour type of base testosterone cycle that, it's completely different. And a lot of our modern medicine is based on that, So when we're starting to get into this, I think it's very interesting that it's oh yes, what did we do? Because we couldn't figure out how to deal with the difference in variable in this basically subspecies type of, people always like to, incel people who like to be oh, the female species, well, okay, fine, research us then, like you would any other, I guess, I don't know, but, what am I trying to say? What I'm trying to say is that, I think it's interesting that a lot of foundational scientific research globally was on this principle of well, if we don't really have a great solution for it, let's just avoid it. It's a later problem. But meanwhile, later involves decades and decades of people's lives and health and things like that, we have so many drugs on the market that women use that haven't been as well researched for them, you know what I mean? That's so wild to me that at the end of the day, no matter what, the people that make money are the ones that get to run most of the show, so they get to dictate the fact that it's not the safety that matters first. We're trying to make it matter, but that involves a bit of trial and error and thalidomide type events, I guess, but I don't know. I think that doesn't seem the right way to be going about research, especially because at the end of the day, half of the scientific discoveries we have out there are accidents. They're accidents. The penicillin guy, he didn't mean to discover that. It was an accident. And now we have a whole class of drugs based off of that sort of stuff, and a whole problem with drug-resistant species just because of that. And you mean to tell me that we need to be super, super, super rigid about research guidelines in this way, where it's an avoid it later because we don't have the infrastructure for it? Huh? I feel like I've lost my own plot now. Like, I know what I'm trying to hint at, and I think I've hinted at it enough, so I'm gonna just roll with this amount of yapping and keep reading. But, yeah, I just thought that was something to introduce, because it's definitely something I'll want to, like, work on as well. Like, as a human being, it's something I'm interested in doing work related to, so we'll see. I think the differences in sex and gender medicine it's important, it's growing, increasingly important, increasingly predominant, and we're also starting to see now the consequences of rushing into certain types of pharmaceutical treatments without that research, decades later after people have been on certain medications for, like, a long time. Not that I'm saying, like, anti-medicate. Take your meds, guys, take your meds. But, there has to be a balance between the safety and the whole, ooh, big pharma makes money. And that isn't always the case. Okay, back to reading. Since expensive and time-consuming testing would be required to know when each woman was in her menstrual cycle at every point in the research timeline, many scientists opted to omit women altogether, both in human trials and in the initial phase of lab testing using animals. Don't get me wrong, I am beyond grateful for the regulation and guidelines that keep women and babies safe from potential complications of medical trials. No one should have to suffer in order to create a new drug or medical therapy, especially not mothers and their children. However, creating a quote-unquote protected status for premenopausal women has had the unforeseen effect of making the majority of medical research male-centric. In an effort to protect women from the hazards of clinical trials, we've endangered them in another way. The pervasive belief that women's bodies and systems are essentially the same as men's has made this male-centric approach seem like a no-brainer in the beginning. But now that we know the difference, it's obvious that excluding half the population from clinical trials and drug safety testing is not only a bad idea, but a dangerous one. Our current medical systems favor male-centrism at every level, from research planning to funding and human trials to implementation in hospital and outpatient settings. In order to show the scope of this issue, I've broken it down to demonstrate how all the various pieces come together to create a male-dominant, male-centric medical model. So bullet point 1, inception. Every research study starts with an idea. For a research study to be approved, it needs to go through a series of institutional board reviews. Researchers need to prove that the study is not only valid from a medical point of view, but can also be conducted with minimal harm to people and animals. Because women of childbearing age were considered quote-unquote protected subjects under the National Research Act, and to some degree still are, this necessitates that female subjects undergo pregnancy testing, which on a large scale can be both expensive and time-consuming, and that female test subjects be educated on the risks of becoming pregnant during the study. Therefore, committees are more likely to approve research projects focused on male subjects or to suggest that a similar approach using male subjects should be considered. In fact, a 2011 assessment of federally funded randomized clinical trials found that only 37% of participants were women. More, 64% of the studies examined quote-unquote did not specify their results by sex and did not explain what the influence of sex was in their findings, did not explain why the influence of sex in their findings was ignored. Oh my god. Okay. Bullet point 2. Funding. All research needs funding. Funds can be obtained from a variety of sources, including institutions like hospitals, healthcare groups, and universities, governments, agencies, foundations like the American Heart Association or the American Cancer Society, and industry and private donors. Because enrolling women in research trials necessitates extra costs, funding it is more likely to be obtained from streamlined male model studies. Funding is more likely to be obtained for male model studies. Also, depending on their own owner demographic, some agencies are simply more likely to choose studies that benefit men. Bullet point 3, publication. Once a research study is complete, it needs to be published in a medical journal in order to be disseminated. It needs to go through the journal editors, then peer reviews to be published. This is a place where both explicit and implicit male bias can occur. Consciously or not, journal editors tend to choose studies whose outcomes are important and interesting to them. And at the time of writing this, most journal editors are, drumroll please, male. Alright, bullet point 4, education. After the research is published, it will be used to educate doctors, nurses, and other medical professionals and inform patient care decisions. However, the information in these studies is almost always presented as applicable to both men and women, regardless of what percentage, if any, of the study subjects were female, and regardless of whether sex was considered to be a variable in research findings. As you can see, from start to finish, our whole medical research process is based on a male paradigm, and time again, women have worse outcomes in areas of high public significance. The good news is, because there are so many steps in the research process, there are a lot of places along the way to make change. But to create a landslide effect, we all need to work in all of these areas simultaneously, as well as we all need to work, but I guess we all need to work. We need to work in all of these areas simultaneously, as well as in the areas of drug research and development and medical education. This must be, quite the experience to listen to, honestly. Okay, our current medical reality. Most of the time, I don't get the information I need to treat patients successfully by looking at their medical charts. I get it by talking with them. For example, if not for our conversation, I wouldn't have known that Rosita, who came in for chronic abdominal and pelvic pain, has been suffering her whole life with excruciatingly painful periods. When she'd consulted her general practitioner several years before, she had assumed this cause was PMS, or premenstrual syndrome. Her doctor had therefore suggested that she go home, take some ibuprofen, and rest with a heating pad. However, the pain increased with every period. Soon Rosita was missing whole days of work, driving to urgent care centers in search of pain relief, and praying for answers, but each time the response was the same. We aren't sure what's going on, so go home, rest, and follow up with your primary care doctor tomorrow. And each time Rosita complied, though her intuition was screaming that something was wrong. This particular month, she was bleeding even more heavily than usual, and in so much pain that she could barely walk. Desperate, she came into the ER. After our conversation, I sent her for an ultrasound. As it turns out, Rosita's ultrasound had the hallmarks of endometriosis. I recommended she follow up with a colleague of mine who specializes in that condition. Exploratory surgery confirmed the diagnosis, and eventually it was determined that Rosita needed a full hysterectomy, which is a removal of the ovaries. And, the uterus, I guess. But, hysterectomy would be the uterus, but I guess I get the tubes. I don't know. Sometimes they list out each word for each of the things, but whatever. Okay. I couldn't deduce this simply by looking at Rosita's chart because there was little relevant information to be found there. Other male-centric medical systems. That was not the sentence. Our male-centric medical system doesn't address any of the subtleties. I was about to say subtleties. What the fuck? Okay. Man. See, this is what I said. Reading in front of the class, you don't even have, you don't have time to recover, because you just gotta, and, I guess I could edit it, but then that's work. It's extra things that it would make me want to do less videos, which feels stupider, so, fuck you, we ball. Okay. Our male-centric medical system doesn't address any of the subtleties of women's issues. We have blanket terms for women's symptoms like PMS, but we don't have a system for delving into those issues in any way that could consistently result in accurate diagnoses. In fact, it takes an average of 7 years for women to obtain a diagnosis of endometriosis. While it may appear from the outside perspective that medicine is systemized to the last detail, this actually isn't true. Despite our incredible technologies and modern advances, much of diagnosis and treatment is still highly subjective, based on educated guesses, theories, pattern recognition, and the occasional plain old-fashioned hunch, especially when it comes to women's health. In the ED, we often joke that patients don't read the textbooks, meaning that they rarely present in accordance with the classic teachings of how diseases manifest. Doctors spend 4 years in medical school and 3 to 6 years in residency learning to put our vast body of knowledge into practice, and yet we still get caught off guard. We all have at least one story about someone who came into the ED with a sore throat and ended up needing surgery for appendicitis or something else equally odd. This indicates not that our textbooks have outlived their usefulness, but rather that they are based on historical averages that no longer fully apply. Most of the data used in medical education was compiled prior to the 1990s and reflects an era when patients waited to consult their doctors until something was really wrong, meaning their disease had progressed significantly and become much more obvious with respect to diagnosis. Now people tend to be more aware of their symptoms and to seek care for subtler issues. This is wonderful. This is not a bad thing. That's my words. This is wonderful was her words, but this is not a bad thing is my words. Now I'm continuing with her words. Because it means that they may catch potentially deadly diseases in earlier stages. But also complicates diagnoses because early in the disease process, the same symptoms can indicate multiple potential issues. For example, whereas people used to come into the ED with full-blown chickenpox, which was easy to diagnose, now they're coming in with a tiny red patch on the arm, which could be the first sign of chickenpox or anything from poison ivy to an allergic reaction. When we try to apply our textbook diagnostic training to unclear symptoms or early-stage disease, uncertainty ensues. Things get even more convoluted when you factor in the many differences between men's and women's bodies. We can no longer ignore the evidence that women in every organ and system, we can no longer ignore the evidence that a woman's every organ and system, from her brain to her bones, from her metabolism to her arteries and veins, is physiologically unique, and that as such, she must be offered different and appropriate diagnoses, treatments, and preventative care. However, I and my contemporaries didn't even have textbooks for this kind of thing in med school, at least not until the textbook Sex and Gender in Acute Care Medicine, for which I was the lead editor, was published. Everything we learned in school was based on the male-centric model, and every procedure we learned was based on male-centric care. Most anatomy books only used male models, providing disembodied breasts and pelvises when female parts were discussed. Mannequins used for simulations in academic settings are male. Usually the only available female model is a pregnant one. Even our electronic medical records use photos of male models. In the ED, we literally have to use pictures of men while we are attempting to illustrate female patterns of pain and disease to women. Different groups of women are also at higher risk in our healthcare system because of a lack of research. For example, many drug trials and research trials do not include elderly patients because such patients tend to take too many other prescriptions, which can confound study results, or because diseases like dementia and stroke prevent the patient from giving informed consent. However, since this population is also the ones most likely to be using the drugs and protocols being researched in these trials, we're left with a huge margin of error. Women of color are also overlooked in research despite their unique factors, and so continue to suffer unacceptable outcomes across the board. We'll talk about this unacceptable disparity in greater detail in Chapter 8, but for the purposes of this discussion, it's vital to note that in 2017, the Center for Drug Evaluation and Research approved over 45 new drugs, which had been studied in over 60,000 participants. Only 7% of those participants of both genders were Black or African American, and only 14% were Hispanic. A 2016 article in The Atlantic noted, quote-unquote, since 1993, fewer than 5% of respiratory studies funded by the National Institute of Health have included reports on racial or ethnic minorities, and fewer than 2% funded by the National Cancer Institute have met diversity goals. And as noted, pregnant women are ignored. Sorry, guys. I'm, holding back this burp, and I'm trying to get it out. Oh, okay. That was a back crack instead. And as noted, pregnant women are ignored by research trials completely. In fact, they're often referred to as therapeutic orphans. Of course, no one wants to create another horrible situation like what we saw with the thalidomide, and thankfully, our current knowledge and protocols would never allow that to happen. But neither is it acceptable that only 8 medications are currently approved for the FDA for use during pregnancy, all of them for conditions related to the pregnancy itself, such as nausea, labor, complications, and pain. Pregnant women get sick, and sick women get pregnant, but because of our reluctance to study pregnant women, the drugs that they take for their conditions come with an unknown set of risks. Women are then left to choose between treating their own serious or life-threatening condition and protecting their infant's health. This is not only unacceptable in human terms, but also puts women at risk for the very same unforeseen complications that we have been trying to avoid. Even Tylenol, which is considered the only safe pain reliever to use during pregnancy and nursing, has not been evaluated in controlled studies with pregnant women. Oh dear, this is bad timing for that sentence. I'm just kidding. Okay, the only difference is that because most medications have not been studied, and once again, you guys can take your Tylenol, just don't drink with it. Be safe, read the back, take your Tylenol, you're fine. It's not going to give you autism. Just don't take it all the time, you know? And if you're taking it all the time, maybe you need something else for pain management, you know? That's the thing, is like, Tylenol we haven't gotten to do those like long-term studies, you know? So like people are seeing like, oh, well, there might be a risk of like dulling the nerves and stuff over the long-term use and blah, blah, blah. But it's like, yeah, but the majority of people for your day-to-day use, you're fine. Please, do your thing. Do your thing, 21. Okay. The only difference is that because most medications have not been studied, the risks and blame for adverse effects falls on the women themselves, who often have no idea that the medicines they're taking are for their asthma, hypertension, depression, anxiety, or seizures, and could pose a risk to their babies. The fact is that despite all the scientific advances we've made in the last 40 years, women still experience poor outcomes in the areas of health, and women of color experience worse outcomes than white women. Women in general are less likely than men to be treated for a lot of things like sepsis or myocardial infarction, for stroke or arrhythmia. Arrhythmia is when the heart doesn't pump at the right rhythm. Arrhythmia, lack of, right? Sepsis is like bacterial infection in the blood, and a stroke is when you basically get like a clot that blocks off blood flow to like the brain, you know. Alright, women also struggle to receive appropriate diagnoses and treatment for women-specific diseases like endometriosis and for chronic pain conditions like fibromyalgia. And women are less likely to be treated appropriately for that great equalizer, pain. Yep. Alright, the lack of widely available information and education is frustrating for physicians who just want to help their patients. I've actually coined the term undiagnosed women's disease, or UWD, to cover the multitude of cases that our current tools can't help diagnose or treat. In her book Doing Harm, Maya Dusenberry called this lack of understanding of women's medical conditions medically unexplained symptoms. The Office of Research on Women's Health in the National Institute of Health refers to women as the 3 U's: understudied, underdiagnosed, and undertreated. If you've noticed a theme here, you're right. Across every area of healthcare, women are less researched, less understood, and quite literally less cared for than men. One problem is that many providers aren't comfortable with a diagnosis as vague as UWD. They'd rather give it a name to what's wrong, and their patients want answers, so they default to a diagnosis that makes the most sense at the moment, even if it's not actually a good fit, just to give some parameters to put around the situation. Such diagnoses are often of syndromes, which is a wastebasket term for a collection of symptoms without an underlying etiology, known as a cause. Rosita's diagnosis of premenstrual syndrome is a perfect example of this. PMS is a collection of symptoms attributed to the event of monthly menstruation, but without a known underlying causation. This was the closest her providers could come to what was happening to her, without a battery of invasive tests, so that was the diagnosis she was given. In order to receive an accurate diagnosis and life-saving treatment, a woman will often need to convince her provider, despite previous diagnoses to the contrary, that something is actually wrong. Women with microvascular disease may have perfectly normal stress tests, but suffer from terrible recurring chest pain, and those same women could drop dead of a heart attack a week later, and have nothing on their medical charts to indicate that they were at risk. Women having strokes can present with headaches or dizziness without the standard, male pattern, droopy face and weak extremities. Because providers don't know how to recognize female pattern symptoms, women often having strokes fail to Oh my god, that was not the sentence. Women having strokes often fail to receive critical interventions like TPA, the powerful clot-busting drug. Women with lung and ovarian cancers, two of the top cancer killers of women, both more likely to be lethal than breast cancer, may present with few, if any, definitive symptoms until it is too late and the cancer has metastasized. And all along the way, doctors without access to critical gender-based information are treating them for the wrong things, unable to diagnose them at all, or worse, brushing off their symptoms as all in their heads, quote-unquote. This points out not only to our inability to properly diagnose women physically, but to also the gender and cultural biases that women face in our medical system, from both male and female doctors. The perception of how women experience pain and the management of women's pain, both in and out of a hospital setting, are highly problematic. Women of color are even more likely than their Oh, God. My throat is so dry. That's what she said. Okay. Where was I? This points out our inability to properly diagnose women physically, but to also the gender and cultural biases women face in our medical system from both male and female doctors. The perception of how women experience pain and the management of women's pain both in and out of hospital setting are highly problematic. Women of color are even more likely to have their pain minimized. One study found that African Americans and Hispanics are less likely than white patients to receive any pain medication, and more likely to receive lower doses of pain medication despite higher pain scores. Women are also more likely to receive a psychiatric diagnosis when they report their symptoms, regardless of the nature of those symptoms. As several writers have observed, the word hysteria or hysterical are derivatives of the Greek word for uterus, hystera. Funny, haha. While formal diagnoses of hysteria are thankfully a thing of the past, there is still a pervasive unconscious belief in the medical culture that women are prone to illogical and unreasonable outbursts. Then, when women express their pain or distress, their complaints are taken less seriously because they are perceived as less likely to be a product of physical disease. Given the knowledge we currently have about the differences between men and women, one might think that there would exist at least a general set of protocols, a criteria for medical professionals to apply when diagnosing and treating women. Unfortunately, this is not the case. Most drug trials, testing, and research studies have been, and in many cases continue to be, performed exclusively on men. Our testing and treatment protocols are developed to identify male pattern symptoms. The foundational research on which our new experiments are based is still male-centric and male-dominated. And despite the growing body of evidence to the contrary, the majority of the medical world continues to assume that, with the exception of their sex organs, men and women are biologically identical. The combination of cultural and procedural bias with the reliance on a male model for scientific inquiry has rendered our current medical system male-centric. And while few practitioners consciously subscribe to the illogic and scientific inequality that has contributed to the creation of that system, they are nevertheless operating within it and according to its rules. The result is that women whose conditions or experiences don't line up with male models are at increased risk of receiving inappropriate, inferior, or even injurious care. It's a huge problem, one I'm working on diligently every day to solve. In my tenure as an emergency medicine specialist, educator, and researcher, I have observed 6 key areas where the biological, biochemical, and biopsychological variations between men and women have created blatant and potentially harmful misalignments in diagnosis, testing, and treatment, both inside and outside of the emergency department. These areas are as follows. Bullet point 1, cardiac and stroke diagnosis and treatment in women. Bullet point 2, prescription and dosing of pharmaceuticals. Bullet point 3, subjective evaluation of women's symptoms, including the role of mental health diagnoses. 4, pain and pain management. 5, hormones and female biochemistry, including prescribed hormones. 6, gender, cultural, and societal conventions, including LGBTQ/transgender issues. In part 2 of this book, you will learn more about each of these 6 major areas of health, where women consistently deal with misdiagnoses, inadequate treatment, and poor outcomes. Each chapter will include not only powerful stories and discussion of specific diseases and treatments, but also critical information about potential symptoms, warning signs, and women-specific treatment options that will empower you to have better conversations with your providers and increase your likelihood of receiving appropriate, potentially life-saving care. By the time you turn this last page of this book, you will have all of the information you need to approach this conversation with your providers with confidence and clarity. Every day brings progress, but until the medical establishment catches up with the science, it's up to you to take a more active role in advocating for yourself and your loved ones. Only in this way can you have an immediate influence on your care and see immediate results. In other words, it's time to join the women's health revolution. Yes, slay, besties, slay. Okay. What matters? Your key takeaways. Bullet point 1. Every area of medical world. Sorry. Okay. Oh God, I hope that doesn't become a stim. Oh no, I can feel it becoming every area of medical world. Fuck. Okay. Every area of our medical world has evolved to be male-centric in a multitude of ways. Next, women are underserved, understudied, underdiagnosed, and undertreated in multiple areas of high public health significance, including cardiac disease, stroke, cancer, and pain disorders, as well as women-specific conditions. If you are a woman, you are at a greater risk of misdiagnosis, improper treatment, and complications in common medical situations. Next bullet is women are underrepresented in clinical and pharmaceutical research trials, and most trials do not account for sex differences as a variable. Next bullet, some populations of women, like pregnant mothers, the elderly, and women of color, are less represented than women in general and have measurably poorer outcomes. Next bullet, doctors often don't have the tools necessary to diagnose female expressions of common health conditions. Alright, and so that was the end of part 1. Hell yeah. Oh my god, I feel so accomplished. Do you? Because, we kind of accomplished it together. So, part 2 is called The 6 Biggest Issues Facing Women's Health Today, and that's where I'll pick up next with chapter 3. Chapter 3 is called Women's Hearts and Brains Break Differently. Oh, that's poetic. Lovely, okay. Man, I'm excited. Also, I just need you guys to know, when I took this book sleeve off, the author was just, staring at me for part of this, because, she was on the back of the sleeve, and, what a badass picture. Dr. McGregor, this is a cool picture of you. I hope you like it. You look really cool. You look like the kind of, I don't know, you got the energy that I hope to exude as a person of that age when I get there, if I'm that lucky. So, alright. I'm gonna stop making book page turning noises, and I think that's about it. Yeah, I do need to do a Mahabharata episode soon. Maybe I'll record one now. I don't know where where did I put the book? I don't even know. And then I'll probably do, I don't know, either I'll do, so one of the things I wanted to do, and I was trying to decide when to do this, because I realized I wanted to, spend more time on it, and then I didn't get a chance to spend time on it in the last episode, but I mentioned Sikandar. Basically, if you remember, and this is such a tangent, but, whatever, he was, in the story, he's basically a charioteer who is reincarnated, and in his, second life, he is born as a female again, but he transitions to live as a male, right? And so basically that's one of the first oldest transgender, human characters we have in a lot of, old Indian stories and mythology. And it's such a, for me as a queer person who's, not even, my own closest loved ones don't fully understand me and my expression of myself. They haven't even seen it fully, really, There's so much that I want to create related to that, because I found a lot of these pieces of me that were just floating out there in the world waiting for me to come catch them over the last couple years, and it's bittersweet to grow away from the person I once was towards the person that I am becoming today, the person I'll be tomorrow, and I love that person. I love this person that I am becoming. I'm happier every day for it. I feel much more myself, you know? Like, every day I feel more free in me, and I think the only way to really understand people is to just talk and to converse and to learn and understand and listen, and I hope that I'll get that chance one day with my family more, but, you know, basically, I don't right now, and that's okay, because there's a lot of other blessings I have in my life right now that are keeping me going, and, you know, I have my gay little support systems wherever I need them, you know, so I'm hanging in there, but that's also, like, a big part of why I want to, I guess, create things that can impact people right now, you know, like, even though this is something for myself, I do know that it's something that could really, like, connect with other people out there, you know, especially other people that might be similar to me or my partner, you know. Like, I literally, the other day, I saw my cousins, and I was like, what did I say? I was like, oh yeah, like, yeah, I mean, he's kind of gay, you know, like, just so you know, like, because I was trying to, like, I never know how to, like, my partner, and, like, he knows this, like, he's not gonna be offended or anything when he sees this. We both are interesting, because he's male, I'm female, we're both queer. We don't care about fucking words anymore. Like, whatever. We're just people, you know, and sometimes he's the one that comes off more fruity, and other people get confused, because they'll get worried, and it's like, no, you don't understand that is, like, yes, like, that is the man I love, yes. Like, there are multitudes to my partner that not everyone gets to see, but also that if you get to know them as a person, you will get to see, right? And you get to see all the sides of someone's gender expression. Like, it's, people are complicated, like, fuck, man, I'm such a complicated person. So, like, to imagine that every other person out there could possibly be anywhere near this, if not more or less or whatever combination, like, that's amazing. It's cool. But it also, you know, it reminds me of, like, how much diversity there still could be out there that I haven't even been exposed to, you know. So I know that there's so much more out there to learn about and see and to take into me as a person, right? And into my life and the way I carry myself through life and stuff, you know? Like, I'm excited for all of that, because I look at the pathway that I've, you know, fucking really, the Sisyphus shit that I've done up till now, and not that there's a payoff, but that the struggle is worth it, I guess, you know, like, I don't feel as though my life has not been worth it, which I think is a very profound statement for me to be able to say, like, on the record, given what I said in a previous video. If you guys watched that, I don't know if you did, but yeah, I don't know, like, I don't want to unnecessarily, I guess, bring attention to that one, but also, like, it feels inauthentic to not, because I posted it for a reason, because it's part of what has been going on with my brain and my life and impacts my everyday, you know. I try to explain it to my family as every day is a choice for me, but I don't think they fully get what I mean when I say that, and I hope maybe I can create something that is able to encapsulate what I mean when I say certain things, like little art pieces in the future, whether it's music or video or audio or whatever. But I don't know, I'm trying, I'm doing shit, living life, trying to enjoy it as much as possible while also being the best version of myself that I can be. I've been adding a lot of accidental L's to the back of words today, huh? Interesting. Alright. Bye, guys. That's about it. See ya.